right. Well, afternoon, everybody. What's missing on the slide here, I was hoping it'd show up, is there is a picture that the VA's Office of the Veterans Experience Office in VA put together called the Veterans Journey Map. It's a very stylized picture of a timeline of what a veteran goes through from joining the military and getting out aging all the way to actually dying. And I wanted to juxtapose that picture with what really happens in life, which is often very messy, very complex, has a lot of priorities that change almost minute by minute. But I wanted to make sure that as we do our work here and go through these clinical scenarios, that I wanted to make sure that folks from the veteran's perspective understand where we see the VA and how we interact with the VA as a healthcare system, which, by the way, is a very small piece of what veterans engage with the entirety of VA, because it has other benefits and services, whether it's home loans, compensation because they're physically injured and due to military service, education. Healthcare is one small piece. It's a critical piece, and somebody had mentioned earlier that it can change. It can be overwhelmingly the singular need a veteran needs, and a day or a month later, it is the last thing a veteran and their family want to engage in. Yes, this slide. Thank you so much, whoever magic that came out of it. I appreciate it. The other thing that that veterans have experienced with the VA was the promise of having the ability to use the healthcare system in a more personalized manner. That really centered around being able to manage their engagement with VA through self-appointment. Ever since the access to care crisis in 2014, MSAs or schedulers, their needs really were not being met. And in 2014 that came to light, and now we are all struggling to meet not only that need, but the promise of what that need has ignored. There's been fits and starts of solutions, but the one that has maintained and sustained our interest with the VA is the My Healthy Vet platform. As many of you know, that is a pretty stable platform. It offers a lot of utility as patients. When we come to VA, it allows us to see our appointments. It allows us to secure messenger our providers, which is probably one of the key aspects of My Healthy Vet that I personally love. A lot of veterans that I interact with across the country always mention that about the Healthy Vet. So, as you know, VA, the veteran population follows the U.S. population. You have millennials, Gen Z, baby boomers, the silent generation, and all their predilections as far as using digital in their lives, much less digital in healthcare, follow suit. It shows up with VA's survey of healthcare enrollees, the last one that they did, and it tends to bear fruit that the older a veteran is as a snapshot today, the less inclined they are to use digital and technology in their healthcare, which is why it's important that when we do this work that we keep in mind the needs of silent generation, baby boomers, to use phones and to show up in person and not use mobiles and apps and things of that nature. It's so diverse and the need is so varied between rural veterans in the Black Hills and the Plain States, Upper Peninsula, Michigan, Alaska, where they don't want to be bothered. Even though they may be having a heart attack, they really just don't want to be bothered. And you have to go in there and try and make their lives better. So I think one of the biggest challenges I think we're all trying to solve, that our organization sees as probably the biggest challenge, is the reformation of the VA healthcare system and relying more on the private sector to provide VA care. When VA sends a veteran out to the private sector, they own that care. That is now VA care. And as everybody here knows, private sector tends to be quite sprawling, quite disconnected, quite fragmented, and frankly, very myopic in how they care for a patient compared to how VA does it. And so as we move forward in trying to design a solution, I urge you to keep this in mind, because the VA healthcare system, any healthcare system, more often than not, is just a very small piece of that veteran's life, and all they want to do is get on and be an active member of society. That's how small healthcare is, for the most part, to a veteran. Important when they engage. And the work here is so important because a lot of veterans at VACs are generally older. They have a lot more complicated healthcare needs, and they face a lot more barriers to care than the private sector, unfortunately. So I appreciate the time, and hopefully can continue to contribute to this discussion. Thanks.
Thanks, Adrian. So as I previously stated, we're going to get started with our first case. It'll be about 10, 12 minutes, and then we will have an opportunity for audience to ask questions for a few minutes after each case, and then as well at the end. David?
Great, thank you. So I just want the audience to think for a moment, to put themselves in this patient's situation and ask the question, what is high quality access? What is high quality kind of delivery of services for this particular scenario? And then we'll hopefully have a conversation based on some of the issues that come up. So Mr. Williams is a 64-year-old gentleman with a significant smoking history who goes to see Dr. Heyworth for his yearly physical. During that visit, they discuss the risks and benefits of lung cancer screening, and they elect to perform lung cancer screening. Dr. Heyworth arranges for the CT scan to occur, and an order is placed, and an appointment happens. His CT scan comes back. It has a 2.5 centimeter nodule in his right lung that was not present on previous imaging. Okay, so it's a new nodule. The veteran uses secure message, My Healthy Vet, to ping Dr. Heyworth to say, what's the results of my study, and Dr. Heyworth requests a video appointment to be made with Mr. Williams and his wife to kind of talk about the results in the next step. And to ensure that happens, the PAC nurse then was required to have to make sure that the room is set up to be video enabled for that next appointment. So after the video connect appointment occurs with Dr. Heyworth, she schedules a pulmonary consultation, which then comes to us, right? So I'm the pulmonologist, and I instruct our pulmonary MSA to schedule Mr. Williams for an afternoon clinic within 2 weeks. He also asked the lung nodule, I actually asked the lung nodule nurse coordinator to arrange a pulmonary function test and a PET scan for the morning of that visit. The lung nodule coordinator worked with PFT MSA to identify available PFT open slots, as well as nuclear medicine MSA to identify available PET openings for the same morning within the next 2 weeks. The lung nodule coordinator provided the MSA with 3 dates within the next 2 weeks for PFTs and appointments. The pulmonary MSA then contacted Mr. Williams within 40 hours of the triage consult to arrange for his clinic visit. He accepted an afternoon clinic visit in 7 days, so relatively short timeline. She then communicated with Dr. Williams' appointment date and time to the nodule nurse coordinator, who then again worked with PFT and PET scan MSAs to finalize appointment dates and times. Their respective MSAs contacted Mr. Williams to confirm the availability. So we have multiple, services and multiple parts within services that are operating kind of hopefully in coordination. Mr. Williams then cancels his pulmonary appointment by vet text. And as the lung nodule coordinator is arranging a multidisciplinary clinic to kind of discuss the case, she discovers that the appointment was canceled, and she has to start working to kind of reschedule the So the lung nodule coordinator then asked the pulmonary SA to contact him and reschedule him again within 7 days. So Mr. Williams was seen by me in clinic at that point to review his PET scan images and his PFT. So that's all done within 2 weeks. So he's had at least 3 different visits, at least 9 or 10 different phone calls to kind of arrange these different visits. And his imaging shows a solitary PET avid lesion in the right lung. He discusses his views with the nodule board and the desire to come in and have a direct handoff with the thoracic surgeons who share clinic with us. And so then we contact the MSA to ensure that there's actually a spot made within the thoracic surgery clinic to allow them for a kind of a warm handoff to occur. So I think that scenario kind of highlights a number of issues, which I think from our perspective, from the healthcare perspective, and from even professional societies, you would think that care actually happened pretty expeditiously and pretty quickly. But from the patient point of view, I mean, he thinks he has a lung mass, and actually his pretest probability is probably greater than 95%, 98% that he actually has a lung cancer. And so although we've coordinated many episodes of care and have delivered what I think objectively by health systems would be considered high quality access to care. From the patient perspective, that patient might actually wonder about, how quickly, that care was, how quickly that care occurred. So I thought I would just kind of stop there. And Dr. Kirsch, do you have any?
There.
So Mia, if you want to comment and jump in about some of the scheduling, I mean, what I hear with that case is there were a lot of attempts and touches and coordination involved, which was not really automated. It was a lot of individuals having to pay attention and intervene. So Mia, if you want to comment on the scheduler perspective in this, it's a lot of scheduling work here.
Sure. Can you hear me? Okay. Yeah, so I agree. I think a lot of the coordination with the nurse and the provider to make sure, one, we understand what all testing and appointments the patient needs, making sure the patient gets the appointments in the right time frame, and if the patient is missing appointments, to make sure they get rescheduled in a fast pace. One thing that you may not think about when you think about a scheduling person is understanding the need of the patient. So if I'm a scheduler and I work in pulmonary, but I don't understand what a nodule means, what it means for this patient to need a CT. So how do I best explain it to the patient without that education? I find that when an MSA who understands what their provider they support is doing and what that could mean to the patient, they have more compassion, they have more understanding, and they have a little bit more motive to move forward and help this patient to get the care that they need. So they understand the criticalness of it and what could eventually be the issue for this patient. So a lot of MSAs learn that along the way, but if we can educate that particular person or persons to understand what is necessary, I think it helps with the care of the total patient. Also, the reminder piece. So the patient has to be reminded of their appointments. How do you do that? Right now, we have a way where we document, but there's no way for the MSA to go back to see what the method that patient wants. So really having a way where if the patient says, I want you to text me or call, or I like snail mail, so send me a letter, so the MSA knows the best method to reach out to that patient, and when all else fails, you make that phone call. And, with the cancellation or using VegText to cancel, this is relatively a new system. We do have the option to cancel. However, we may not follow up as frequently as we probably would want to. And having the system, they're in separate systems. So you'll have a cancellation in VegText, so it'll show up on a report, but you don't get an alert in our system currently, where the MSA knows, oh, this patient just canceled, or that's Mr. Williams, we really need to get him back in. So an alert system that would help us understand when a patient cancels so we can see that readily and be able to document that and alert the provider or the nurse of the team so they understand that, the person that you wanted to critically come in has now canceled. So there's a few thoughts about that role.
And I'm also wondering, Mia, about the way that a scheduler determines or knows if something is more urgent or not. Because I know that this morning we touched on prioritizing patients, and maybe that's a good thing or a bad thing, but we all know that if our family member had a lung nodule, we weren't certain if that was cancer or not, we would want that to be done pretty quickly. And so what is it that a scheduler in the current state has to acknowledge that versus what we might want to see in the future state? And then I might open it up to Chris and some others about the urgency and or the coordination piece for this case.
So that's a great question. So currently when an MSA goes in to schedule a patient, without the education of the team to let them know what's urgent, they don't know. So they could project or they could assume. But I think it really relies on the team to explain to that MSA what the urgency is if it's not written in the order, if it's not written on the actual document. You can say have this patient scheduled in 7 days. Okay, so if I don't have it scheduled in 7 days, then what? What's the urgency on it? So I think it's really important to have an open, honest communication, but also a way for the MSA to review and receive that communication if that provider is not in person with them. So right now we have the RTC order, where a provider, return to clinic order. I'm used to acronyms, we work in the government, right? So the return to clinic order is where the provider would document and explain to that MSA how they would want that appointment scheduled. They could include the urgency, they could include the no later than date, and make sure that information is available. So we do have that does help with communication. So that's one way we currently do it. I think we can enhance that just by, with our focus on the resource-based system that we plan on doing and making sure that we have the time allotted in the space for that and just more education for the MSA.
Thank you. Chris, from a care coordination standpoint and that role that sometimes nurses really help us with, would you like to comment
Sure.
on that?
There's a couple of things that I think are also key when you're talking about how the team coordinates as a whole, and that is that oftentimes the nurse has the ability to coordinate or communicate really more effectively with the MSA and be that go-between between the clinician and the MSA. But even more importantly, I think sometimes is making sure that when we're talking to the veterans that they understand why we're doing what we're doing. And so we heard that seen in clinic within 7 days. There's a need for us to make sure that the veteran also understands why that is such an important date. And so there's different ways, as we heard earlier, that veterans are generational and what they like to hear, how they like to use technology, but it's also how we deliver that information that sometimes is important to remember from a generational standpoint. Our frail and our elderly population may not necessarily understand some of the language that we use versus our younger populations that tend to be a little bit more savvy and know how to navigate systems a little bit more effectively. So really making sure that they understand when we're having those conversations. The other thing that I think is important to remember is that veteran that we're talking about has all the right things in place for us, but that doesn't always happen for us. And so we need to be conscientious of the fact that maybe the veteran has a phone that we can vet text or use that information, but from a skill set, they may not have the bandwidth where they live to be able to do video chat. They may not have the technology savviness to be able to navigate all the pieces. And so it's really important for us to know what they are experiencing geographically that will allow them to engage with us at the level that we would like to engage. And as folks know, in the VA, there are rural areas that are very difficult to navigate when it comes to making sure that we're using technology to our advantage. But if we're not able to use it specific to that veteran and in their home, what other opportunities exist? And so making sure that we engage technology to maximize that, and really working with the team to say the patient may not necessarily have the ability to do VA Video Connect, where they may not be able to VTEL in. Is there another location close to their proximity that we can send them that allows for that same type of technology that allows for the efficiency? The other thing that I think is important is we talked about the multiple appointments that have to be scheduled and coordinated in order to get this patient through in a timely basis. And I think from a scheduling perspective and from a care coordination perspective, we really need to be able to leverage as much technology as possible to see what our capacities are in each of the areas where we are trying to get that patient care. Because a veteran, especially as our folks get older, their ability to travel becomes more and more challenged. And so to overlap some of these appointments on the same day or within a close proximity is going to minimize the impact or the inability for that patient to be able to make all their appointments. So I think it's really key for us to use all of the technology to coordinate. What's able to be seen on the same day is availability. So hope that helps.
And then when we think about how our veterans use VA Video Connect, which is our video telehealth platform, we want to think, as Chris mentioned, about what their connectivity is like into their home environment, having the resources to train them to be proficient so that this is not a frustrating experience for them that they never want to do again. And making sure they have a caregiver who's engaged if that's relevant. And sometimes the caregiver will be physically present with them. Sometimes the caregiver might be a child or somebody who is in a physically different location. But our scheduling of these video appointments allows us to also bring a caregiver in so that they are also receiving the link in their email to join that appointment so that everybody is present. The other option that we have, depending on the actual needs and where video telehealth might be relevant, is the ability to bring in vital signs, do a remote physical exam. And this is something that will expand over time as technology develops. The use of the virtual stethoscope, weight scales, exam cameras, etc. So providers, schedulers can be very thoughtful about what can I do by a remote exam, and what really does need a hands-on exam and a face-to-face appointment.
Thanks, Leonie. And I'm really particularly intrigued that as we delve into the video world and what is appropriate or not appropriate, I don't know that anyone really has all the answers in this arena. I think that giving an important lab result, we all have done that over the phone quite a bit, but I think that having it, if they live at a distance in a more rural community or have challenges in traveling, that using Video Connect is a really into the future way of engaging with patients. I think I'm going to ask Adrian to make a comment, perhaps about this case overall.
Sure. Yeah. So, I like the dialogue here. That the thing, part of the thing that I ask myself when I listen to the case, and the scenario that unfolded is, first of all, what does the team know about the veteran? Does he have transportation issues? Does he have a caregiver? Is it a spouse who's also frail elderly? Is it a young professional daughter or son? Because all of that can impact or can have a direct impact on the kind of access the veteran needs. I do know that in My Healthy Vet there is a notification or communication preference. In fact, I have an appointment on Monday over at the DCVA, and today I got peppered with some confirmation texts, calls, and robocalls, which I don't know if somebody planned that or not, but that's what happened today. Yeah, but I mean, I think out of all of this, the thing that stood out to me the most is the anxiousness that a veteran may have as a longtime smoker, knowing full well that this is probably going to, get him in the end, and then having this come up and the anxiety that patient may have. And so the question I would have is, in this idea of access and quality care, that patient education, just to activate that patient to take a more active role, is a component of scheduling. But I think that's an important component to keep them engaged, to follow up with any future appointments or being compliant with a treatment plan. I wonder if that, and I hope that will be part of the design moving forward, that this is much bigger than just, the clinical passing of the patient across settings.
Thank you so much. So I'm wondering if we could go to the next slide, please. So let's see if we did a pretty good job or how we fared with addressing some of what our group thought were points within this clinical case. I think we highlighted this lung nodule, an urgent issue, not emergent, but something that we recognize we would like to have addressed for the veteran in a relatively quick fashion. The use of Video Connect as a vehicle for delivering care, hopefully, as Adrian points out, based on a preference and being veteran-centric. That this case, there were a lot of touches to the patient, and how that care is coordinated is important. I heard Chris share about how nursing plays that role and can help with that role, and that helping the MSAs, the schedulers, understand that this is important, either in a systemized fashion with a return to clinic order or sharing that information with your team, and the schedulers, MSAs, are on that team. The timing of the appointment, and then I think we addressed some of the coordination. So this is at first pass what we thought that we were sharing with you all, but I'm going to open it up for a few minutes into the audience if there are comments or questions that you would like to add. Please go ahead.
This is Joe Camaro from HSR&D. Great case, sort of a classic, right, in terms of cancer diagnosis and treatment. And when we think about sort of time to treatment or time to diagnosis and time to treatment, when you're thinking about this across the VA, one of the questions that we have in our system as well too is in the scheduling department, who is accountable when it's one thing if a patient actually cancels, but if they no-show to that follow-up appointment, who's scanning the environment and saying, this is going to delay that diagnosis and treatment? Is it the specialty? Is it radiology? Is it primary care? And how does that work in the VA?
I can answer from an administrative perspective. So for schedulers, usually you have a supervisor, and the supervisor is scanning to make sure that you have any no-shows, seeing and communicating with the provider and the team to see what do we want to do with this patient. So the best format would be if there was a daily huddle, the clerical person was involved, the lead or the supervisor to communicate with the other clinicians on the team, the nurse, understanding what this no-show means. And so if the provider says, yes, we need to get in contact with this patient right now, having the MSA reach out, and sometimes the MSA coming back to that clinician and saying, I've tried, they're not answering, and the clinician taking the initiative to say, I'll call, and once I call, let's just be ready to schedule and get that patient in.
So I think it's important to acknowledge that when a consult gets put in, if I'm the receiving specialist, you anticipate that you've got that patient scheduled for the day, and if through something like vet text that the patient cancels the appointment, it will show up as a canceled appointment in the scheduling package. But you have to know to look in it, and you have to know to look for the patient. Sometimes we're so busy in our days that we just keep going, and we rely on the MSAs to say, Mr. Smith canceled or Mr. Smith rescheduled, and until we have something that triggers it, it really is difficult for us. I think would be incredibly helpful is, and I think we touched on it earlier, is having that technology that automatically notifies without having to go to look for that notification, that gives us the ability to say, this is a flag, this is what we need to follow up on, rather than having to wait for someone to spoon feed it.
Great, thanks. And one last question to keep us moving
Mike
through the
Davies,
cases.
VA.
Thanks, Mike.
What I noticed was in this rather ideal scenario, it was a great care. I mean, this is sort of the current state in VA. There was 7 appointments. If there's a 5-day wait between each one of those appointments, that's 35 days. And it looks like it happened in 2 phases. There's kind of a diagnostic phase of figuring out you have a lung nodule. That was 3 appointments. And then there was at least 4 appointments in the treatment phase. Now, what I wanted to challenge us to think about was our daughter's experience at the Mayo Clinic. We had a diagnostic phase, and then when we went there for treatment, they did all of the appointments together in what we might call itinerary scheduling. 1 trip, same day, 2 specialists, 3 diagnostic tests, end up at the treatment phase and walk out. So I think where we want to get to in the future, is something like that, which is a much harder sort of level to achieve. maybe than doing this sequentially.
Absolutely. Thanks for that, Dr. Davies. I'm going to turn it over to Dr. Heyworth, to Leonie, to lead our next case on heart failure.
Thank you. So we will be focusing a lot on multidisciplinary team coordination in this heart failure case. So our patient is going to be a 54-year-old man who is undergoing cardiac bypass surgery. So think about all of those care elements that need to be included in follow-up care, not only with the surgeon, the cardiologist, the primary care team, the rehab team. In this case, we're also going to throw the community care wrench in there as well, just to keep us all on our toes. And since it is, T minus 3 weeks before Mission Act Live, so very relevant. So Mr. Johnson is 54 years old. He's admitted to the hospital for cardiac bypass surgery. At the time of his discharge, his very technologically advanced and patient-centric primary care team conducts a video discharge appointment. So his primary care team, most likely the nurse on that team, is conducting a video appointment from the community-based clinic where Mr. Johnson is usually seen to the medical center or the community hospital where Mr. Johnson is getting his surgery. So Mr. Johnson might be there with his iPad in bed communicating with his care team, who might be 20 miles away and closer to his home in the place where he's usually seen and where he's going to follow up. So for discharge planning, his inpatient team recommends that he follow up with a cardiologist, a CT surgeon, a clinical pharmacist, a psychologist, a dietitian, and his PCP. So he is going to be just as busy as our veteran in case 1. He's also going to need a repeat echocardiogram in 4 weeks, along with home-based primary care. We understand post-surgically, particularly with a coronary artery bypass, it's going to be hard for him to get around. So we're arranging patient-centered care into his home space, where we have providers who will physically go to his home in our home-based primary care program, along with home remote monitoring. And this is our home telehealth program. I think it was Don before that referred to his dad having had this 15 years ago. Is that right? Your uncle. Close. Uncle Harold, sorry, that's right. So the home remote monitoring, our home telehealth program, is going to allow him to submit his daily weights as well as daily blood pressure checks. He does qualify for cardiac rehabilitation. He's going to need a community care referral because his local medical center doesn't offer that service. And then as a result, the community care consult will need to be placed in order for those services to be rendered. Okay, we're going to go to the next slide, see how he progresses. Oh, okay. I guess they were reversed. We can go back to our key points at the end. Okay, or not. We'll go forward and do our key points now. So the inpatient case manager works with the MSAs in cardiology and surgery to arrange, as we noted, a number of follow-up appointments, as well as that appointment for the echocardiogram, which, remember, he needs 4 weeks after that surgery date. So the medical team also places a post-discharge hospital consult so that he can be seen within home-based primary care. And the MSA in his PACT is the patient-aligned care team, so his usual frontline primary care team, appoints a visit for him to be seen 2 weeks after his discussion, that video discussion he had with the nurse on the team. And then a community care consult is also placed so that he can get that cardiac rehabilitation in the community. So, of course, Mr. Johnson lives a long distance from the medical center. So what he's requested is that all cardiology and surgery follow-up be done either through VA Video Connect, because he's savvy with his iPad, or on a same-day basis if possible. So he'd also like his wife to be a part of his visits. She's managing a lot of his medication, a lot of his wound checks, a lot of his dressing changes. He's willing to travel to the medical center, though, to receive his echocardiogram. So we will want to make sure that we notify him that he is eligible for community care so that he can get the cardiac rehab. We understand that he's willing to travel to the medical center to get his echocardiogram, so that care can be rendered within VA. So for home-based primary care, we have a team who will be seeing him post-surgery actually in the home. So this team will be a primary care provider in addition to a nurse who will actually make physical visits out to his home, as well as visits by video telehealth interspersed with those in-home visits as needed. For that VA Video Connect visit, I mentioned we have the ability for caregivers to join, and so Mrs. Johnson has already expressed that she's interested in joining those Video Connect appointments when they occur. For the home telehealth piece, and home telehealth, remember, is our name for our home remote monitoring program, Mr. Johnson is going to submit daily vitals. So he will have a box sent to his house with equipment allowing him to check his blood pressure, check his weight, his pulse, and have that information be submitted to the frontline team, who will then generate a report and share that with Mr. Johnson's providers. So that is with equipment loaned to him from the VA. So the home telehealth nurse is going to process this data, put it in the electronic medical record, engage the clinical pharmacist if needed, so that a disease titration protocol can allow them to adjust diuretics as needed, even when Mr. Johnson is at home between visits. So as Mr. Johnson improves, he's going to be transitioned to Annie. And Annie is our text-based mobile application. There are various protocols within Annie. So we're going to start Mr. Johnson on the heart failure protocol. So it will send him a text on his phone, and it will remind him to check his weight. He might not need to be bound with all the VA equipment from our home monitoring program anymore. He can use his home scale and simply text message back to his provider. It goes into a database. Providers at VA were horrified briefly when they thought they would be getting personal text messages of every blood pressure and weight from their patient. But the provider can go into that database and basically look at the graph of whatever it is that they have on them on protocol for. So blood pressure, weight, in this case, would be the most key. As far as what Mr. Johnson is doing for community care, because remember he's getting his cardiac rehab in the community since the VA doesn't offer that service, there's a number of steps that I think we should break down and discuss, and Desiree is going to take that part.
Yeah, so here we go. Thank you. Hi. Yeah, so for a scheduler for the community care process, it becomes the community care consult that was placed by the provider. It gets forwarded to community care. That scheduler then contacts the veteran, asks them if they do want to opt in. Do they want to go out to the community for this? They are eligible because the service is not offered in their area. And then once the veteran opts in, then there needs to be an authorization. Well, first, once the veteran opts in, then they need an appointment in the community. And then so the scheduler would contact the community and make the appointment in the community. And then after that appointment is made, then we can go back and let the veteran know that there's an appointment there in the community, and then the authorization would have to go over. So the scheduler then brings in any medical records that the community may need, as well as work with a third-party authorization to get the third-party authorization, and then also send that over to the community provider to let them know they're authorized to see that veteran. Basically, they're going to get paid. And so that's the whole process for the one veteran, for the one appointment for cardiac in the community.
I wanted to make one brief comment for those that may not be as familiar. We have been outsourcing care for a very long time, so this community care program and process is not new to VHA. We're really just consolidating it, and there's a bit more press about the way we're doing this and the partnerships into the community, but we have been doing this work for a long time, right, Desiree? I mean, you've been using, sending people out in V basis for a long time.
Has been, yeah.
But I'm wondering if some of the highlights, if you want to comment on, as I listen to this case, there's a lot of complexity and a lot of planning, a lot of work on both the side of the providers, the scheduler, and the patient to accomplish. And so we have some of the key points here. if you guys want to comment on that or make some other comments from the perspective of the scheduler, or Cliff,
I'll
go
just
ahead.
make a quick comment on related
From
to
the mental health
from the
standpoint
behavioral-
of the
in
patient
this case,
here.
from the behavioral health standpoint, for cardiac rehab. Leonie mentioned we'll see a psychologist. Our home-based primary care teams have a psychologist embedded, so we will be sending a psychologist out to their home to see them.
And I think this case really uniquely highlights not only the coordination between multiple specialty services within VA, but also outside VA, as well as the new technology and old technology. Our home telehealth remote monitoring program has been in place since 2003. And then also that the new definition of community care that we'll be rolling out. So touching on those things, we have that coordination piece with the clinical services and the community. The caregiver part, I think, can't be emphasized strongly enough, particularly because this is a post-surgical case. Even if it wasn't, as Adrian alluded to, caregivers play a very big part in many veterans' lives. Some of them are official and compensated through the VA, many are not, and serve a critical role in supporting the healthcare needs of veterans. The post-discharge period has been a point of a lot of focus as far as what kind of care is needed to bridge that transition. What's the best thing to do? Is it for the primary care nurse to make a phone call? We're now thinking more about integrating video and not having it be post-discharge, but rather the ability to move it up and say, well, let's actually have the two teams talk to each other. The team that's going to be taking care of the patient on the outpatient basis and that warm handoff from the team who's on the inpatient basis, and that maybe at a VA hospital or maybe in the community. Synchronous telehealth, not to be biased, but could play a huge role in that transitional piece and really allow for more enhanced communication, having that visual aspect and that remote physical exam as well. We touched on our home-based primary care program, which allows many of our homebound veterans to get all the services they need in their home space, ranging from primary care to including their behavioral health needs. Our home telehealth remote monitoring program that is modernizing to include mobile applications. And I'll just mention the Annie app that I mentioned is named after Lieutenant Annie Fox, who was the first woman to receive a Purple Heart. She was, I think, Navy veteran, if I'm right. So.
Go Navy.
And I'm wondering, I was wondering if you could comment also about, since we're here to share some of our successes, but some of also maybe our dark spots instead of our bright spots, about what it is like currently in doing some of the clinical video telehealth and telehealth scheduling, and then what we hope to look forward to. Probably we have about a minute, and then I'm going to open up to the audience so we can keep moving. Desiree, and then if you want to comment on that as well.
And I was just talking about the bundling the appointments and knowing, I guess from a scheduler's point of view, I just want to know what the veteran needs at that moment. So what do they need? Do they need the community care appointment? Do they need to go, do they want the video, VA Video Connect appointment? I would like to see that in the future in the preferences so that I know to offer VA Video Connect, I know to offer telehealth, and that I know maybe, this is not for them, or that the caregiver is going to be there and it's okay to leave that message with them. I think that would be something that I'd like to see in the future for scheduling.
And the scheduling setup for video?
Correct. One system would be fantastic.
and I can mention a dark spot. So right now our scheduling system, I'll pick on mental health, is stop code driven. It's bucket driven. So I have a PTSD clinic. But so let's say my face-to-face appointment for PTSD care was a no-show or canceled that morning. So I'm technically free this hour. I could do a VA Video Connect appointment, but I don't have a clinic, so I can't. Right? And if the MSA runs down the hall and sees I'm free, can you see this patient? I'd love to see the patient, but I don't have the right bucket. So that's one of our current challenges.
Absolutely. And the setup in the current telehealth system through the telehealth management platform, which was set up quite a number of years ago, right, is separate than our Vista scheduling system. So we hoped and look forward to a future state with Cerner where that is more facile. So that would be one of the things that we hope would be a key characteristic into the future. Dr. Kaiser?
So somewhat along the lines of what Dr. Kimura asked in the last, in the additional wrinkle in this case is the community providers. And how does the system deal with when the community provider decides to not be available when the appointment is scheduled, or something happens that the cardiac rehab is not going to be available? How is that designed into the system so that you will know in advance that that's something that has to be dealt with, since it's not, a priori part of the VA?
So, I'm sorry, you're speaking if we don't offer it, or because we wouldn't?
No, when the appointment is scheduled with the community provider and it's all set up, but the provider decides to take that afternoon off to go play golf or do something else.
Right,
and
right.
So that schedule is canceled in essence, but not by the patient, but by the community provider. How does that link back into the system?
Yeah, it comes back to us in community care, and then we have to start it all over again. We start the process all over again to schedule.
And is that automated so that you know immediately, or is that
so a lot of the things
or?
we have to search for. So, we're coming to these reports. We're talking about return to clinic, consults, community care consults. We have to search for them. So we do have oversight where we're provided these reports to look at, but it's not a real-time alert to say. Mm-hmm.
How does a patient know in advance?
Right, that's a good question.
If that provider cancels, you mean?
Yeah.
That's right. That is a gap in our current system.
One thing just to add, though, if it gets to a point where it becomes urgent, the VA does have built-in provisions for community care to go out to get urgent care for that patient since the time frame has passed, so that they can get that care if we don't have it in-house.
So, can I follow up on one more point related to that, which is that I think there's a fallacy that community is there to serve gaps in our ability to deliver care. But in highly rural areas where we do not have service, the community also doesn't have service. And so that's something that needs to be considered as we're kind of building into these models about how do we actually start thinking about how do we deliver that care. There are some services which are largely intellectually driven that could be satisfied with, virtual face-to-face visits or the like. But there are other services that require a small amount of procedures, either by technicians, where they may not be satisfied through just purely intellectual exercises. And we need to start thinking about how we actually start delivering service where service actually does not exist, period.
Next question, maybe the last question before we move on to the third case.
Sure. So I just hope you can hear me okay. I just wanted to ask if you could highlight a little bit more around how you account for the caregiver in the video visit workflow. You have that highlighted throughout this story, and so whether that's invitations for that caregiver to participate, I know, how do you make sure that that caregiver also has that on the calendar? Because a lot of times our caregivers do go to work and might be joining from work on a lunch break while veteran is still at home or dad is still at home or whatever that looks like. So I was just wondering if you could talk a little bit about that.
Yeah, and that's most often the case when they are joining. They could be joining from anywhere. The car seems to be a rather popular location. So we can, when we schedule the visit, there's a place to say add caregiver. So you just, as long as you have that caregiver's email, you can put it in at that point. Or when the veteran receives their email, they can forward their email to anyone. And so as long as you're in receipt of that email, you can join the video session. If there's regret as to who the veteran ended up forwarding it to at the time of the visit, the video provider can actually mute and disconnect whichever participant they wish to.
And that's, I think, a functionality as we look into the future that we want to maintain. So I'm going to turn it over to Dr. Lisa Arfons for our next case, please.
Sure, thank you. So this is Mr. Smith. He's a 32-year-old IEF, OEF veteran, and he's a student. He has type 1 diabetes.
I know what that is.
Oh, I'm sorry.
I want to make sure. Yeah, we use a lot of acronyms.
Yes. So he's Iraqi Freedom, Enduring Freedom veteran. So he has type 1 diabetes. It's a service-connected condition for him. And he would like to spend his summer traveling around in an RV, visiting his fellow veterans. And during this time, though, he still wants to touch base with his endocrinologist and his diabetes coordinator. He would like all communication by way of his smartphone, ideally, because he's going to be traveling in an RV. His smartphone will be his connection, but as we talked about in certain highly rural areas, he may not always have even that connectivity. So his primary care provider at the Cleveland VA, where he lives, places a traveling veteran coordination, otherwise known as the TVC consult, and requests an initial visit with the diabetes coordinator at the Orlando VA in 4 weeks. So they discussed loosely his plan. He's a 32-year-old gentleman, single, isn't going to plan a whole lot, but certainly will be starting out by going to Orlando. So, there needs to be ongoing communication with the traveling veteran coordinators at multiple medical centers throughout his journey. Before we, I think, continue on with the story of this case, just to fill people in, the reason I think this case is important is, first of all, this is a true story. Second of all, we are seeing that we are serving younger veterans, and they have very different needs than our older veterans. So I have some veterans that I care for who literally have moved their homes to live closer to the medical center because they are at the brick and mortar shop so often. And we have other patients, such as this one, who, is I think really part of sort of the modernization of the VA, that, they want to be able to touch the VA at any point during their journey, wherever they may be, geographically and medically. And so this is geographic diversity in one individual, and I think that we're probably going to be seeing this more and more. It, as I said, kind of speaks to the limitations of a brick and mortar shop. We need to provide care wherever this patient is. And it does speak, obviously, to the need of interfacility coordination. So we've talked about the hub and spoke concept, and this is just a bigger version of that. Finally, I have used the Traveling Veteran Coordination Consult for my patients, and I think it's fantastic. So I have used the old model when I would just sort of put it on my veteran to say, all right, you're going to Phoenix for the winter, head on over to the VA, they'll see our records, let them know who you are, and hopefully you'll get in. Now, with the Traveling Veteran Coordinator, I know who the coordinator is in Cleveland, and I can reach out to her at any point after I place a consult or even before and say, hey, can you track down this patient for me? I'd like to know how he's doing, or she can pull up data in the Joint Legacy Viewer for us, and so we can really keep track of patients. So before we go on, Mia, you were really integral in developing the Traveling Veteran Coordinator program, if you can speak to this, because I do think it's unique to the VA.
It is, and something that we have to consider, and then Adrian's going to comment as well. Go ahead, Mia.
Sure. So I played a little bit of a part. It was already developed when I joined it, but one of the things that people didn't understand is what's a traveling veteran coordinator, because it's kind of unique. So within the VA system, we have the ability to have patients' records seen across the country from VA to VA to VA to VA, right? But what you don't know is that each VA only turns on that ability when that patient needs that care at that particular hospital, to try to contain and try to control people's accesses to individual social security numbers and date of births. So you may have one person in the entire facility who can see anyone's record across the country because they have that ability and they have to make sure that that happens. But if you're a clerk or you're a physician, you may not see it until it's loaded into the system. So we have a process called one registration. So once a veteran's registered for the VA, they can be seen across the country. We have a really cool way where we can enroll you from site to site to site. So once you have completed your application to receive services at the hospital, at this particular hospital in Orlando, if you go to a Nevada hospital, they have a click of a button, they do 3 steps, and then that patient's information is pulled from the Orlando VA into that hospital into Nevada. So it's a really cool mechanism, and then, everything pops up, it's available, all schedulers can see it, all providers can see it, so it makes a world of difference when a veteran's traveling. But some of the issues that do take place is that sometimes our people don't know that happens because if you don't see it, you don't think that patient is getting care anywhere. So sometimes it results in a patient having to go back through the whole entire registration and enrollment process. Yes, sir, you have to complete that 1010EZ again, that application for care, when they really don't. So I think we have a bit of a task of ourselves to make sure everyone understands what that process is. Plus, the idea is that there's a traveling veteran coordinator at each location, so then when that patient is traveling, that whatever medication they're missing or service they need, when they arrive at that other place, their vacation spot, they can get that information. I know I forget my medication every time I travel. So it's like Walgreens stop is the first place I go. So this is kind of like that Walgreens. Like our patients are able to go to that VA, go to that pharmacy and be able to get that prescription refilled or see Dr. Arfons if they need to see Dr. Arfons. Sometimes our communication from the interfacility consult from the originating place of that patient's care to the travel place of that patient's care doesn't quite link up. Again, the patient's information has to be in the system for the interfacility consult to show up. If that process is missed, then you have a gap. So some of those systems that we have could be a little bit quicker and not as manual so that it does happen at an instance, because we do have a little bit of once the information is sent, somebody has to pick it up. Somebody has to load it. It's not necessarily completely automated. But when it works, it works. Mm-hmm. So that's kind of what the traveling veteran coordinator position is. This just makes sure the care is coordinated from one position, from one facility to another while that veteran's traveling.
And does the traveling veteran coordinator, at least in our facility, it is an RN who also has scheduling capabilities, which I don't know that we've talked about a lot, that some of our clinical providers do have scheduling capabilities. Is that pretty standard?
So it varies across the country. So you'll have some traveling veterans, coordinators that can schedule, and in others they have to rely on an MSA or a scheduling person once that information is in to coordinate that appointment process. So it's not standardized across the country as to who has that ability. I think what is standard is just having that coordinator in place and making sure they're available.
And I think it's also important to know that in addition to the RNs and MSAs, they also have some facilities where they have clinicians that are actually identified as that traveling vet coordinator. And I think for me, the most important thing I think is important to remember, and again it comes back to generational, it's not just our young folks that like to move around the country. I worked in a VA in Florida for about 17 years before I moved to Mississippi, and there's a term called snowbirds. And so it is an extremely large population, depending upon which VA that you are working in, that receives that population from the 1st of November or the end of October right through Easter. And so you really are reliant on having that traveling vet process refined as much as possible, because there is a lot of reliability on those veterans to be able to move around. And the other population that I've noticed has an increasing request is our chronic disease population, like our dialysis patients. They're no longer held hostage to one facility because they understand that there are options out there and things that we as an organization need to be able to provide them to make them mobile. And that is one of the things that we've seen an increase in, is that chronic disease state.
And I just heard the Phoenix facility director speak at an event last week, and she mentioned that for their snowbirds, they literally have a surge of about 30,000 patients within just a few weeks. So they see a really dramatic change. I think all of those people actually come from Cleveland, but so I've offered to go there with many of my patients, but so far no one's taken me up on it.
Or sunny Seattle in November.
Other comments from the panelists before we move to the key points?
What I'll add is that you don't necessarily have to have a veteran see another provider at a VA if they're traveling. And so what I like to do a lot with my patients, because the veteran population is incredibly mobile, they'll say to me either, I'm moving to the LA area, but just for a year, I want to keep you as my primary care provider because I know if I disengage from your panel, I'm never going to get back in again. So we'll just do whatever we need to do by telehealth. Maybe I won't even need to see you, but if I need any labs or radiology or something specific, then I can enter that into the traveling veteran consult request, but just for that specific lab or radiology or whatever it is procedure that I want, not necessarily for clinical care if I don't think that's needed.
and it will ask you if it's temporary or a permanent move as well. And also for like this patient, for instance, hemoglobin A1Cs, you could receive those then electronically without having to bring the patient into the facility, anything. So, all right, so I'm not really, I think in the interest of time, going to go through the rest of the case because I think we made our point. Let's just make sure that we covered the key points.
Can I make one summary comment?
Yes.
Because you guys have been in the details of some of the case, but one thing that this brings up for me that I wanted to share with the audience, and that is most of us don't have the opportunity to have health care where when we go to another state or we go on vacation and it's in the United States or American Samoa or Guam or Puerto Rico, right, that we could connect into our healthcare system, right? Does anyone have that functionality? Because I think with the Veteran Health Administration system, Veterans Health Administration, system, we have that opportunity. We've initiated some processes in place. We want to perhaps keep those processes and even enhance the way that this functionality exists. But this is something that's unique as we move into Cerner. The scheduling, the view, whether not having to go see a new provider again, I think is really a very advanced healthcare system, and so I just thought that was really hitting me, pretty strongly that this is an opportunity as we move to one electronic health record that we can do that. We don't have to place all these interfacility consultations and wonder whether one site would be able to view the records at another site, but I think that functionality can become a bit more seamless. That was my overarching comment, and if you want to make a few kind of summary comments, and then I can open that up to the group.
First of all, did you want Adrian to comment?
So she kept asking me if I wanted to say something,
Okay.
but you guys kept saying things that were like spot on, and so I decided not to. But I will say this, and it's kind of hitting. There's a couple of times it's come around now that the systems that are in place to support people are quite passive. It sounds like, and because we're being asked, we as in VA is being asked to do more with relatively less, we might want to turn that around a little bit. The other thing that I heard, and I want to key in with Dr. Kirsch, is that we're all creatures of habit, right? So what we like today as veterans about the VA, please don't change it. You may think you're making it better, but you got to ask us first. When we had, I was just mentioning this decision, we actually worked with VA back in 2011, 2012 on the handbook for traveling veterans. Because a lot of DAV members, so we have about 1 million members in our organization. They're all military injured. All of them are military injured. And our population in our organization is much like in VA. The vast majority is Vietnam veteran, Korean, very small, but Vietnam veteran. Persian Gulf War veterans now overtaking the VA as well as our organization. And so you now have a population that is both computer literate, savvy, and digitally inclined, as opposed to what tends to be the more complex, frail, elderly patients you have now. So our members came up and said, why is it so hard for me to move as a snowbird from the Northeast to the Southwest? And hats off to VA for coming up with a handbook and clearly moving it far forward than was contemplated when we first met with VHA leadership on this, making it a more seamless process for veterans, even having to re-enroll when you actually only need somebody that specifically has a capability or credential, I don't know what the term is, inside the VA healthcare system at the front office to just click the button and say, you're in. And to ensure that veteran's treatment plan doesn't face any disruption. It's such leaps and bounds. So please don't get rid of that.
And I wanted to make one other overarching comment for those in the audience not as familiar with VHA. I don't want anyone to think that we encourage our clinicians to be schedulers. We want them to do what schedulers, what they do best, which is take care of patients. I do think that and we're currently have a policy that's about to come out about minimizing the amount that certain clinicians do have that spend their time scheduling in an effort to really align the most appropriate resources that are clinical to veteran clinical care. But it is a unique position, that traveling veteran coordinator, because they may have to facilitate medication distribution, right? Chris, you're kind of nodding your head on that one. And so I could see where there would be that dual role, and I don't know that exists in other health systems as it does in ours. Go ahead, Chris, you want to comment?
I think the other piece that's key to remember as well is, depending upon the volume or the population that you have as traveling vets, really it's incumbent upon facilities then to really put the resources to that, so that you're not reliant on just one person who can manage up to 30,000 veterans, on the 1st of November. And so in some facilities, there are MSA support, there is the clinician or the RN that will allow that to be a little bit more seamless and not necessarily burden people with multitasking, but maximizing people's experience, education, and training. So,
thank you for that comment. Comments from the audience at all, or questions? Do other health systems that you're familiar with have functionality with when you're traveling? I mean, okay. Ken's going no. Okay. Oh, thanks, Eva.
The VA has a very interesting system. Is that you have one identifier for patient, and so I think this is the one that all the private sectors have no ability to share, right? And I think this is really unique, and I really love that capability. But then it also makes your scheduling a little bit more complicated, because it truly requires the sites to be integrated, right? To be coordinating. It doesn't have to be perfect, but at least you need the connectivity.
Absolutely.
And I think that would be
and that was kind of the point that I was trying to get to. Thank you so much.
And for care coordination, because I think because they have so many different sites doing all the lab tests and everything, so you would like to be able to get all these information so that you see the whole picture as you actually treat the patient.
Absolutely. Thank you so much for those comments, and I think we're going to go to our last case. Cliff?
Mental health case. Mr. Erickson is a 32-year-old veteran. And let me start before I continue. In mental health, there is no wrong door. So to initiate mental health, you do not need a consult from primary care. You don't need a consult from anyone. So you could be a direct referral. You could walk into a mental health office and ask to be scheduled. This is just one example, which is common in the VA, is coming through primary care. So that's we'll proceed from there. So our 32-year-old veteran has been seen by Dr. Heyworth for his yearly physical in the PACT clinic. During the visit, they discussed the ongoing challenges the veteran has with sleep disruption and ongoing social isolation. The veteran denied a history of thoughts of harm to self or others, but acknowledged he has been increasingly isolated and withdrawn. Dr. Heyworth requested a warm handoff with the co-located PCMHI staff. The PCMHI staff visited and identified a more chronic mental health history, and Mr. Erickson was interested in seeing a psychotherapist for care. During the initial intake, the extensive history of decreased mood and sleep disruption was identified. So the intake psychologist, Dr. Patterson, requested a telemental health appointment in psychiatry and a 12 weekly 1-hour visits in order to initiate cognitive processing therapy. Next
Cliff,
slide.
can you comment on what PCMHI is, please? Thank you.
So in our example here has several buckets. So in VA, we embed mental health professionals in with the primary care team, the PACT team. And that could consist of a psychiatrist, it may be a psychologist, it may be a social worker, it may be all three of them, depending on the size of the facility and how many veterans are present there. We encourage same-day warm handoffs in order to increase engagement into mental health care. Our primary care mental health integration teams essentially they're built around 5 models, but scheduling-wise, some teams may be complete open access, in that all of the mental health, the co-located mental health staff there have a completely open schedule and are ready for any warm handoff. Another model may be an alternating model where they are scheduled at the bottom of the hour, and at the top of the hour, it's all open access. So you always know somebody will be available at the top of the hour. Scheduled follow-up appointments are at the bottom of the hour. The model is built upon a problem-focused treatment care, so it's 30-minute appointments, and it's brief. 2 or 3 appointments at most. If more care is needed, they would go to the specialty care, and in this case, that would be Dr. Patterson in our general mental health clinic. In the general mental health clinic may also be team-based care with a psychologist, psychiatrist, nurse practitioner, and may have a peer support specialist. There may be multiple professionals there in that team. Next slide. Is it? Okay, so I'll go back. So one thing I wanted to highlight in this is we have multiple scheduling needs in mental health. So the first place the veteran started was co-located in with primary care. And that's a specific bucket. Those would be specific providers. There was no consult needed because it was a warm handoff between the primary care provider and mental health. And so that takes care of a consult need. To go to a different level of care, it's typically going to be a consult would be entered to be scheduled. The challenge we have, like with Dr. Patterson, is Dr. Patterson needs the ability for weekly appointments. Right? If Dr. Patterson's schedule is so full they can only see the veteran once a month, that's not evidence-based psychotherapy. So the challenge we have with scheduling is how do you make sure you have the availability for that weekly appointment as appropriate, but have good flow, right? So it's one thing we wrestle with and struggle with is graduation or termination of care and to go back to the next or a different level of care if needed, or back to primary care for management. In our example, we have psychiatry, and that's another scheduling difference, right? There's typically their follow-up appointments are going to be 30 minutes, but with the initiation of care, we have to make sure they have access for follow-up soon after the initiation of care so we can monitor side effects, his medication, doing what we would expect, and then follow up in 6 months, or as appropriate. So we have the multiple providers involved. We have different buckets or places involved, and then we have the whole coordination of that. What if there was the no-show, similar to the community care? And it was asked earlier, who would then follow up, right? So if we scheduled them for the psychiatrist and it was a missed appointment, who follows up? And what do we do to ensure we are following up? So that's our kind of our clinic approach in this typical outpatient. From the scheduling perspective, I'll leave it to Mia and Desiree, but it's a challenge for our MSAs because I could make it more complicated if I was looking at, is this PTSD care or is this substance use disorder care? Because that may be 2 different scheduling buckets.
Yeah, so as a scheduler, I can hear all of I don't hear all of the fantastic work that's going on with the care coordination and the caregiver and all of the things that are lined up or the intimate conversations that they're having with the mental health provider. So when, the warm hand, in this situation, the warm handoff for the VA, I can see improvements in, right now we have a process where we have great access. We have the teams that are located, the pharmacist, the social worker, the psychiatrist. But the patient has to have an appointment made so that we can show our access. So I believe that Cerner has that solution where, we can add an appointment or it's unscheduled, and so that we're able to show that we have access, show that our providers are able to deliver that service and get all that credit for that. But at the other end, say that in our current state where the veteran does not get that care, they walk out, they no-show, they get a phone call. I wanted to stay and talk to the mental health provider, but I didn't have all day. I only had an hour off of work or something like that. That these conversations that the provider and the patient are having somehow flow up to the scheduler, so that I'm not making any decision making as to what comes first or where they left off in their treatment. So I am giving that veteran what they need, what they've discussed, and not re-explaining why it went in this order or trying to become the mental health expert about why you missed this appointment and why it's important. So hopefully in the future we can connect that language that's happening between the back office and the front office.
So I want Cliff, if you could, and Desiree to comment a bit more, because many of you are quite astutely aware our mental health care, suicide is really, and all of our substance use disorder, opioids, really front and center, very publicly announced on a regular basis. Some of the nuance of all these different stop codes, which makes this very challenging, the way mental health is scheduled, was really done, in my understanding, Cliff. Well, why don't you share why some of it was set up that way as it relates to media and reporting?
So our buckets exist. The stop codes exist for financial purposes.
Can you explain that a little bit more of the stop code?
So
that is.
Every clinic is assigned a location. So I'll pick on our PTSD clinic. So if I'm a PTSD provider, I work in this location, right? And so all of the work that I do is PTSD related. So there's a code that's attached to my clinic, and so that's called a stop code. And so for mental health, that's 562. So if somebody somewhere in the big VA system sees workload done in 562, they know, oh, this is PTSD care. And if we spent $4 million on 562, when Congress asks me how much money did you spend for PTSD care, I can go, well, 562, $4 million. So it's one way that we report the work, or we're able to assign costs to the specific places where our staff work. The challenge of the stop codes is it's been applied broadly, so it's not just about managing money any longer. It's about managing workload, productivity, utilization. It has become much broader. And so it's challenging within mental health, because if I'm, say, a PTSD provider, so my clinics are 562, but this veteran now needs to be seen, and I'm available, can I see him? Well, but it's not a PTSD-specific clinic, so if I see them, it's going to get captured in the wrong place. So for me, from the mental health perspective, what I need the scheduling system to be able to do is be flexible, but give me the nuances where, like, I can report to Congress. Congress wants to know how many of X, Y, and Z. So a common example right now you may have seen is we're providing care to other than honorably discharged service members. I was in a recent interview and paper from Seattle, and the reporter wanted to know how many within each of these buckets. And the reporter wasn't happy with my, I don't know, because we don't have the ability to slice like that at this point, because it's so new that the system isn't designed yet to tell us that. So that's one of the current scheduling system helps me know those nuances.
And I think as well something, and then David, that we need in a future state scheduling system, the ability, because we do answer to the Congress to track some of the information that we've been tracking in a different way. It is inhibiting to us, but in the future state, we need to be able to track the work that we're doing as it relates to mental health care. David?
Yeah, it applies to even more than that. It reflects on, how VA measures productivity. And so to accommodate that situation where you have certain buckets and you can only see patients, you should only see patients within those buckets. At one point in time, we had actually created open grids to allow whoever called us on that particular day to come in and be scheduled into a particular time frame in a particular clinic, so that we could capture the workload credit appropriately. But at the same time, there was then that our open system, which would just really be in for walk-ins, was then viewed from a productivity standpoint as all this open access. And when we had wait times and people going out to the community, why weren't these people being brought in for these open grids? And so, as we kind of build a system kind of de novo, we have to be able to accommodate not only the direct issues around around actually scheduling people into the right places, but also think about think about how that system might be used in the future around productivity or other ways that it hasn't been necessarily designed for, or putting constraints around it so it's not used in ways that are not really appropriate.
Leonie, did you want to make a comment?
I'll just note that of the 12 consecutive weeks of therapy, a lot of times telemental health is something that a lot of veterans opt for, and we do a ton of telemental health at VA. So if you think about veterans who, like Adrian said, they have their own lives. They want their medical care, but then they want to get on with their life. So they may have caregiving responsibilities. They can't leave home because they have children that they have to take care of. Maybe they only have a lunch hour to do that session, and it's going to take them an hour to get to the medical center and then wait to do their session. So that can be a huge way to make sure those sessions are actually consecutively attended for the full course. The other piece that we recognize is that not all veterans want to come to the VA. Perhaps they don't yet have the trust of the VA behind them. These include women veterans, veterans with military sexual trauma, and others. And they may say, I prefer to receive care in the comfort of my own space. And oftentimes that is into the home. So it allows us to avoid those missed appointments and continue that continuity of care. The other point I'll make is we talked about that PCMHI, which that integrated healthcare team. There are some clinics that we have in our VA healthcare system, so-called contracted clinics, that don't have that full complement in the front line. And so often what those clinics will do is bring in a telehealth provider from a different facility. And so there can be that warm handoff, but it may be that the veteran goes to a room in the clinic to receive telehealth care. And it is timely, it is that warm handoff, but it could be from a remote provider.
I just want to join in this comment real quick. So again, Leonie, another person on this panel, was talking about or made a comment about something I want to bring up. Mental health is a very personal kind of care. You may give us access, but if we don't have a relationship with that provider, you might as well just have me talk to my grandmother, which is a different issue altogether. The concern that I have with the future of VA and how veterans engage the VA healthcare system now is how porous it's going to be as veterans have to flow in the community. VA is now just starting to engage the community, the U.S. healthcare system outside of VA campuses and clinics on suicide prevention. The system that we are going to be sending veterans into don't quite, not because it's a willful ignorance, but it's a hobby to them. It's not what they do. It's not what they breathe. It's not what they're inculcated in. And so when you have a veteran who goes to VA, first of all, I want to make sure everybody understands that veterans who get mental health care in VA tend to be a very resource-intensive patient. Healthcare is just one, but they have several other needs in general. And so those needs, my concern is their ability to be met in the community, notwithstanding access and scheduling, presents a whole range of other issues that perhaps is within the scope of this work, but certainly much broader. The only other thing I want to bring up is VA has inpatient capacity, and we fight every day to make sure VA has that, because the private sector just does not, and it's one of those just-in-time cares. Mm-hmm. I remember one time we had a homeless veteran who finally said, I can't take it anymore. I need housing, I need shelter, and I need treatment. And it took 3 or 4 facilities to find a bed 4 states away. So that's the access that this veteran had at that one golden minute to get him off the street back into society. And I just take that for a comment, I suppose.
I appreciate Adrian's comment there on we are relationally based, and so scheduling has to take that into account. I can easily fix the access problems for mental health in the VA. If I'm a service chief, and let's say I have 4 psychologists on my team, so that's 6 appointments a day, so 24 appointments a day, individual appointments. I can mandate no more individual appointments, group session only, 1-hour appointment, 10 veterans each. I just look at all that access I created and how easy it will be to schedule group appointments. But I've just done something to our quality. Right? I can make an open access clinic, but now I probably have changed the working relationships because now the veteran isn't likely to see their therapist anymore. They have to go to an open access clinic rather than seeing their provider. So for me, the most important part of a scheduling system is, are we enhancing the opportunity to that key component of mental health, which is relationship-based?
So one thing to add on to that, because all those different variations of how you were changing how we schedule patients, for Desiree and I, it probably equates to a number of clinical profile changes and relearning what those clinic names are, and then training the schedulers to know which patients to put in which clinic groups. So it becomes complicated. It's easy probably from the clinician's perspective, because the thought is, oh yeah, I can just change this and now it's a group appointment. It's no longer an individual appointment. But in behind the scenes where Desiree and I were trying to work it all, she's cleaning up the grids and creating more space and trying to do exactly what you asked, because we're not a resource system. We're a specific stop code system that we've been using. So now the MSA it went from 1 or 2 grids to scheduling to now 10 grids, and having to understand which patient goes in which grid at what time, how much time. So in my ideal world, it would be great if we didn't have to go to that minutia of using stop codes. But if Dr. Smith has a clinic, he has 10 clinics, and we can put any patient he asks to put in there for whatever reason, for however many minutes he needs to see that patient, or if it's a group. Because it does become more complicated sometimes when, in theory, it's a great idea and we're changing it, it will work, but when we're trying to make the actual moves in-house to make those things work, it kind of becomes a little bit more complicated.
I appreciate that, and I think that I want to, for everyone who works in the VA now, who's in the audience, on the panel, in the audience, who has worked in the VA, has led the VA, mental health care is something that we take very seriously, are very passionate about, and absolutely do not want to share that as much as we can unless really, really appropriate into the community. We've worked very hard to ensure that our programs continue to exist and are there for veterans, because we do think we deliver unique services. So with that thought, I want to comment on, we can turn to our key points in a moment, but I want to know if Desiree will comment on something that we talked about. I forgot to tell you this, Des.
Get ready. Get ready.
So yes, I want
Me is thinking that there's a lot of things there, but there's a lot of things. But and that is around suicide prevention and our core mission to engage with the Veteran Crisis Line and with follow-up appointments, and how that is a unique thing that we offer in VHA, and then have Cliff or others comment. But the coordination and the critical nature of a veteran who calls the crisis line and how they get follow-up and how some of that is coordinated, I wonder if we could comment on that and then go through our key points and open it up more broadly to folks.
Yeah, so, and then as we're talking here, I'm thinking about just the relationships that are, again, bonded in it's called the back office, and then the relationships that get bonded in the front office. So as a scheduler, you really get to know the patients. As the provider, you're really getting to know the patients, but to really bridge that gap. For instance, we were talking about if, the veteran calls the crisis line, and they have a conversation, and then, maybe they call the call center, and then they just want to make an appointment. Maybe they're an established patient with Dr. Smith, and I offer them the next available appointment, or I ask them when do they want to come in, and maybe it's a week or 2 weeks, or maybe they have a return to clinic order that says that they should be back in 2 months. Wouldn't it be nice to have a system that told us that this person just called the suicide crisis, the hotline on Friday, and they're calling me on Monday. I think I need to escalate this to Dr. Smith. So just bridging the gaps between the information that I know is already there, and bringing it really to that relationship between the scheduler and the provider.
Yeah, that I remembered that in our conversation so much that I wanted to actually bring that up here. So thank you for that. And so let's take a look at our key points. If the panelists want to comment on that, and then we'll open it up.
Sure. I'll just quickly run through these. I think we hit them all. So our mental health in the VA is comprised of a broad spectrum of services, from outpatient, residential, inpatient. You mentioned the VCL. I also consider that as part of our spectrum of care. Our programming incorporates many medical specialties, physicians, psychologists, social workers, RNs, recreational counselors in our supported work employment, peer support specialists, through a variety of modalities. Individual, group, intensive group, meaning 3 or 4 more hours a day, 3 days a week. So the appointments can vary from same-day open access, warm handoffs, scheduled, weekly scheduled, 4 hours a day scheduled. I just think in residential, we may have a residential program with 200 beds, so 200 patients, each with 5 different classes or appointments that day. So that's a lot of scheduling just in that one little system itself. Scheduling challenges, we talked about these. The right person at the right time. A common experience in mental health is I'll sit down with my patient. What brings you in today? And they look, well, I got this letter in the mail. And it wasn't to see me. They needed a psychiatrist. Instead, they're now with a psychologist. So we missed an opportunity there, right? So right place, right time, sustained follow-up. We can't be crisis-focused only. We have to provide treatment in order to reduce the crisis opportunities. Intensive treatment, multiple hours a day, and we haven't talked about it in this example, but we also have self-scheduling. So the applications where a veteran can self-schedule their appointments. Those are high-level key points.
So other questions around this specific case before we open it back up again and try to summarize the key discussion points of this overarching session? Chris, you look like you want to say something.
So the only other thing I wanted to add, and to Desiree's point, when we have the crisis line calls and having that automatically generate messaging to our frontline MSAs. Similarly, when we have patients that we flag in VA as high risk, those are also going to be critical pieces for us to be able to integrate into that same algorithm where there is an automation that helps the MSA to be able to have that handoff or that conversation with the clinician to say, Mr. Smith is a high-risk patient and he just canceled his appointment. Those are the kinds of things I think we in VA really, we miss opportunities sometimes that are otherwise what I would consider to be very critical. And as technology moves us forward, I think that integration is going to be key for our success.
We have a number of significant predictive models. One is the high-risk flag, our REACH vet, high risk for self-harm, other harm, STORM, which is an opioid use predictive model. And we have a NIRMO, a predictive model for no-showing. The challenge is those models are beautiful. We have wonderful dashboards of patients, and here's the risk, and we can identify staff to reach out. But that's all separate from our schedulers. So our schedulers never see that the predictive models would say that this veteran has a 90% chance of not coming to this appointment.
The way that we saw in the previous.
Correct.
Yeah, we wouldn't be able to see that, Eva. Yeah, and that may be perhaps an ask for the future state. Do you want to make some comments or you have a question? Go ahead.
In listening to this, I didn't keep track, but there's probably a couple dozen things that I heard that would not be part of a scheduling system in any private system I know of. The crisis line connection, multiple things. And I'm wondering what is being done to capture all these little things that actually come out of real patient experience and to kind of memorialize them so that you can go to your new vendor and say, these are things that we have to have because this is real life, and these are the real types of circumstances that we have to deal with. I mean, how is that being dealt with, and how are you capturing this information so that you can in turn take it to Cerner, who then can take it to their coders and the folks in the EHR, and try to make some of this connectivity that, again, I don't think exists in any of private scheduling system I'm aware of.
I guess I'm also curious to know if Cerner is reaching out to advocates like Adrian to get input.
Well, I think we're in the beginning of the Cerner journey. That we don't even have any sites that are going live yet. We're still, we had a planning meeting on April 1st to initiate some of what we're going to start with. And this really is a segue, frankly, into that work. I have to be honest and say when we cooked up this plan, I didn't quite realize how rich of a discussion this would be. It really has even opened my eyes to a number of things. And our office, and I'm the business owner in the standalone scheduling component with Dr. Davies and Jeff Lowe and several of us that are working in this arena with Cerner and the Office of Electronic Health Record and OINT. But this really is, I think, the beginning of our opportunity to do so. So other comments or questions? I don't know if you want to make a comment or a question.
I just want to...
Oh, I'm so sorry. I was looking there. Go ahead, Adrian.
So Dr. Kaiser, you, and some folks on the panel, please correct me if I'm wrong, but your question is very salient in that it wasn't but 2 or 3 years ago, and if I hope I remember his name, I think it was Scott Blackburn, who was tasked at one point to he had realized, or under his leadership, there was a recognition of the amount of data that VA has. There was just not a lot of data mining efforts. I don't know what's happened to that, but it was very promising. I went out to UPIT for a conference there with regards to that. And there were a lot of things that were talked about, a lot of ideas and proposals. To talk just about that, it reminds me of a lot of what we're doing in our organization about learning from our members and how we engage them to better understand them. In other words, the challenge would be for VA to better understand the veteran and not just themselves as a health system. And so that, I think, is the biggest missing piece that I hope will be part of what's going forward.
Thank you for that, Adrian. And we have a few questions back here.
Yeah,
Go ahead.
I was just going to add from the Cerner perspective, I think we have aligned very closely to the Office of Connected Care with Dr. Evans and
That's true.
Kathy Frisbee and Teresa Hancock from the My Healthy Vet team, and they've been instrumental in sharing and helping educate us on sort of not only the design decisions that have been made in the My Healthy Vet portal to date and why those exist, and the business decisions that exist and the experience that exists today and why it is the way it is, but also kind of what their vision is for it. And that helps both align where we think Cerner plays a big role on the patient experience and how we can help advance that, and then where do we need to adjust to help align with their vision. And so they've been an incredible advocate for us in that space, and so they're sharing quite a bit of, I think, a lot of that research that has happened over the course of even the last 24 months with the introduction of VA.gov, and how do we navigate that and help make sure that veterans get to the right place. So they've just been hugely impactful for us as we understand that world. I actually got up to let Drew step in, but I think since you pointed my way, I wanted to make sure that you guys understood kind of how our connections back into that world worked.
Yeah.
Great. Good afternoon. I'm Ashley Griskowski with the Office of Healthcare Transformation with VHA. I actually have a question. While I was listening to the cases, it was becoming more and more apparent to me how complex it is for patients to actually schedule that appointment and how many different schedulers are actually involved in coordinating that care. And I was specifically thinking about that from the CHF case perspective, especially coming in and out from the inpatient unit. Now you add in the community. And I was thinking specifically back to this morning's session when somebody mentioned about keeping our MSAs in the system, making sure that they play a role in growth in the organization. And I didn't know what we're doing to do some kind of a care coordination, or have we thought about the scheduling component like we do for nurse care coordinators, and potentially employing that type of a cross coverage, a multidisciplinary scheduler to help with that one veteran and to be able to speak to one patient or one scheduler to actually get those appointments coordinated. So I didn't know if there was any comments from the panel or from the audience, but that was something I was thinking about.
So I think some sites have individually, locally developed that kind of a clerical support. But ideally, yes, you would want a scheduler who could do a multitude of appointments to kind of centralize and streamline where a patient has to make appointments and not have to go to a million different places. I think the challenge is that we have so many different clinics that sometimes it can be a little bit more complicated because they're not as standardized for the MSA to coordinate and be able to schedule. Also, I think, getting more trust into the system and making sure our MSAs are standard across the board too. So having them be able to be trained to do that level of work, so then every clinician knows that if, they have an MSA, it's a great quality MSA, we're going to get the same type of work out of them, and we believe that they're going to do this work that we need. So helping to coordinate a little bit better.
And you've done some of that work trying to set those standards and for us to be able from our office to provide training and support, and do really believe, based on the feedback of the implementation in Columbus, that there will be more satisfaction at the level of the schedulers. While it will be a high level of coordination, as we've heard from our cases, that they're really the way that the view and the error rate, as Dr. Leeron pointed out this morning, is substantially lower. So I think in some ways the life will get a little bit better, but there is absolutely a level of coordination that the system, and this is just, I think, pervasive in healthcare, needs to provide, and what can we do to support that is a critical question. Go ahead.
Yeah, this isn't really a question, but there's three things I picked up on that I just want to validate. Maybe I'm hearing wrong. One was this tension between we need these data to report to Congress, we need these data to show our productivity. From the point of view of a patient could care less. It's just such a disconnect that keeps infiltrating our system. I mean, all the software systems we use for EMR were set up for billing and not for patients and not for physicians or nurses. So that's got to be reconciled somehow in the system, because a commercial provider will push you towards whatever they think is the thing that you may want, but they don't really know. So that's one. Secondly, Leonie's comments were really, really right on target. I think knowing when you need a psychiatrist, when you need a psychologist, when you need somebody like my wife who's a social worker, does psychotherapy, and when you just need a computer. I mean, the computerized CBT is really pretty good, and NASA uses it for astronauts. I think, that's a pretty high-risk population when you think about it. So thinking about that, when you need to be in person, when you need to be virtual. I had a psychologist for a while, and after 5 trips into Cambridge and paying parking and going up her 3 flights of stairs, which is hard for me these days, I didn't want any more face visits with her, and she was perfectly willing to accommodate. So that was really on target. And finally, I haven't heard much about techniques that are used by ethnographers to really understand the experience of patients. It's again, things that are really not that new. I mean, 15, 20 years ago, Michael Rich at Boston Children's Hospital gave camcorders to asthma patients living in Roxbury and Dorchester and asked them to record their experience with asthma living in poverty. And that was transformative to the physicians who saw it. Kaiser Permanente, I think, has trained over 400 people in video ethnography now with cell phones or the kind of devices we have today. Shadowing patients. These kinds of things are absolutely powerful. Having worked with Cerner a lot at Boston Children's, at least during the early stages of our installation, there was none of that. And thousands of hours of physician and nurse and microbiologist hours were spent talking to Cerner. I don't recall any of that kind of ethnography where they really understood what patients want and need. So I think the comments we heard from Adrian were spot on. And if that isn't planned, I would spend a lot of effort persuading Cerner to do that.
Do you want to make a comment, David? Do you want to comment about the ethnography and the...
Yeah, I was going to make a comment. There is actually one EHR that was developed by watching providers, and that was CPRS. Actually, Vista was designed around providers and provider behavior as opposed to revenue generation. That's actually one of our issues now, is that it's being used for separate tasks, as you alluded to. But I think the ethnography question is hugely important, and it factors in two ways. It's the human design kind of factors that play into not only how patients accommodate the recommendations that we make and the suggestions that we make around care, but it's also how we as a health system behave and interact with a new EHR that's coming, but also how we interact with each other and the kind of the structures of healthcare. We do not do that nearly enough. That is an area that's I think is completely ripe for better understanding. But we need more systems engineers. We need more medical anthropologists who can sit and observe and work with us collectively. You're going to follow up.
Yeah, great comments. Thank you so much for that. I know I'm about to get the 1-minute warning. So.
Stand up here. I don't like to sit down.
Did you have a final comment, Lisa? Or? Oh, Leonie did. Go ahead, Leonie.
I think one thing that really informs the growth, development, and expansion as far as telehealth programs at VA is our close relationship with the evaluation and research that's done through our they're called HSR&D inquiry, for those people who know. But they really provide us a lot of rich evaluation and feedback. And For example, for our Digital Divide tablet program, we did a set of qualitative interviews to understand why veterans, if they did, thought that this was a service that they would use, that they would enjoy, and what their experiences were. And as we embark on these telehealth access points at veteran service organizations, we too want to understand what demographic of veteran would go to this place and receive care services here. Is that something they even want to do? And how can we build and design around the unique needs of veterans in those communities?
So I think that I was going to make a final comment, and then we'll see if Dr. Kaiser wants to add anything. But I really feel like you guys exceeded my expectations. I think I invited every individual and spoke to Adrian as well about how we might craft some information sharing with the audience and then solicit input around what has been emphasized is a lot of our unique programs, the massive amount of coordination it takes, the unique needs and the ways that we need to support our schedulers doing this work, and what our task is moving forward, and the partnerships that we need to really engage in to make this a system that is totally veteran-centric and makes it easy for our employees, both clinicians and schedulers, administrative staff, to do their job. So I want to thank the panelists for their incredible insights and input, and thanks the audience for your participation.
Outstanding panel. The one thing I'm left with, and this may resonate with Don Goldman a bit, is that it seems like we've only kind of scratched the surface on where we need to go as far as understanding the complexity of patient needs, the programmatic or array of programs, and there are so many other situations that it seems like we should be mining that data to really figure out what input needs to be given to Cerner. There's just lots more that needs to be uncovered, I think. So we are at the anointed time where we can take a break. We will restart in 15 minutes at essentially or close to 3:45 for the last session of the day on interoperability and related issues, which again promises to be very good. Dr. Kimura will be moderating that. So we'll see you back in 15 minutes. Thank you.